right, we're going to talk about, just like Dr. Pinto has his passion with MRI, and it's worked out so well because of the work, all the work you've put into it over so many years. I think people listen to you talk, but don't realize all the hard work and the team and the frustrations one goes through in developing new technology, and the doubts different than taking care of patients. We have doubts about what we're doing to our patients, but when you develop new technology and you've dedicated yourself, it's almost your entire career, and you have the doubts about, is this really going to work? That's the hardest part, I think, Peter. I've been through that with brachytherapy, and we're going to be going through this with what I believe is going to be another way, or can't say yet it's a better way because we don't have any clinical data because it's still in development, but it's another way to look at how to better or best identify patients for surveillance. So prostate biopsies, we used to do a lot of them in the US, 1.2 million times per year and almost 3.5 million times worldwide, but recent data suggests we're down to about 750,000 cases of biopsies a year, and we've decreased the number of prostate cancer cases. There may be consequences to the reduced number of biopsies, as Dr. Lucia told you this morning, and that's going to come back to haunt us. We never seem to get things right. We go from one extreme to the next, and what's going to happen when we finally do realize that we have more cancer cases because of the decrease in the use of PSA and prostate biopsy, and how we best going to solve that. We need to also recognize that prostate biopsies are mostly done in the office, so they are trust procedures. That hasn't changed in over 30 years, and that the mapping biopsies done very infrequently. It's done more often in Europe and in Australia, but it's only about 5% of the procedures that we do in the US, and it needs to be done in the operating room because we put the patients to sleep, but that may change because some companies have come out with new devices that allow you to do a perineal biopsy in the office under local anesthesia. So the history, it's interesting to look at the history of the biopsy procedure because these two papers came out at almost the same time in the late 1980s, where Fred Lee was proposing a transrectal biopsy and Guy Valenciennes was proposing a transperineal biopsy, Valenciennes from France. And we know who won that battle. The trust biopsy became the predominant procedure, but they both were reported at the same time. Next slide. This is one of the studies I like to talk about because it gets to the heart of the issue about how to identify patients with active surveillance if you're using a trust biopsy. And this is a French study where they had 990 men who, based on the biopsy criteria, met very stringent criteria for selection for active surveillance because it was just one core positive with Gleason 6 less than 3 millimeters. And they found that only 26% by strict criteria would have fulfilled the criteria for active surveillance management out of these 919 men. And we all know this, that there is significant risk of upgrading and upcharacterization of the cancers if we rely just on the trust biopsies using the typical criteria. So 26% of the patients had quote unquote insignificant tumors. We can argue whether that number should be more closer to 50% based on criteria, but still the message here is trust biopsies alone are not adequate to select patients for surveillance. And we can argue whether the very low risk patients are good candidates if you're relying just on trust alone. So the bottom line with the trust biopsy is that only 25 to 30% are positive. 25 to 30% need repeating because of false negatives, and we've seen patients come for mapping biopsies who had 7 negative trust biopsies before they had their positive mapping biopsy. And I think Dr. Pinto said yesterday he sees as many as 9 negative trust biopsies before the patient had an MRI. I believe it's got limited usefulness for selecting active surveillance candidates. It really can't be used for selecting patients for focal therapy. And it's hard to change practice patterns because the trust biopsy is an easy and quick procedure to perform in the office. And as a urologist, we don't want to be spending time in the OR just to do a biopsy, especially with today's tools. So it's no wonder that the task force doesn't like PSA, but it's not the PSA that's the problem. It's the biopsy that's the problem. And whether you're using an MRI to help you biopsy or using a mapping biopsy to help you biopsy, we need to make changes in our practice patterns, because what's happened is the backlash is now causing patients to show up with more disease, and so we've got to do something different. So why would we want to know more information about the prostate? So you can interrogate the prostate with an MRI, or you can interrogate the prostate with more biopsies. We really want to determine the true pathology or risk group of what's in the gland. We want to improve lesion localization so we can improve our approach to definitive therapy. And the precise lesion location and grading may provide a pathway for targeted focal therapy. And I believe that we can probably get to the point where 50% of newly diagnosed prostate cancers can be treated by focal therapy. We do it with breast cancer. We don't do mastectomies in the majority of women who have a small lump in their breast. And why are we doing that with prostate cancer? We can't do it today. I don't have any confidence that we should be using today's technologies, whether it's image-guided MRI or transrectal biopsies, as a platform for designing successful focal therapies. I think we're going to miss too many lesions, and we're going to find ourselves focal therapy, image, focal therapy, image, focal therapy, and the patients aren't going to tolerate that. Just some slides on MRI. This is the issues I see. That's the problem with MRI is we heard about, this is from Lenny Marsh's group at UCLA, we heard about multifocality. It's about 75% of the men have more than one lesion. Same was found here in Lenny Marsh's study at UCLA. But the issue for us is if you're looking at lesion size, MRI missed 73 to 89% of lesions smaller than 10 millimeters in diameter. And if you cone down and just talk about Gleason pattern 4, it was about 30 to 35% of the lesions were missed by MRI. Now, it's okay if you're using the MRI, so you put a patient on surveillance, you get an MRI, and that patient has a lesion that can be targeted and biopsied, and then you eliminate that patient from screening because you found a higher grade lesion. But like I said before, it's not what you see. It's what you don't see that gets the patients into trouble. And how important is that? Data shows that when a patient has a Gleason 8 prostate cancer as small as 0.2 cubic centimeters, that those tumors are already starting to become metastatic. So for sure, if we can find the high-grade tumors when they're smaller, and we can find those patients who have Gleason 6 and nothing else, that's a much better solution to figure out how to manage patients. So I do agree that active surveillance is really not a passive procedure, because you got to do multiple PSAs, you've got to do repeat biopsies, although we're starting to decrease the number and frequency of the repeat biopsies. But why isn't it like colonoscopy? If a patient comes in and has a colonoscopy and there's nothing there, we say come back in 10 years. We don't do things every year to that patient. Even if the patient has a couple polyps, we usually say come back in 5 years, we'll take another look. So why aren't we managing prostate cancer that way? So I would suggest that we get rid of the term active surveillance, because I don't want to, if I'm a patient, I don't want active surveillance. I don't want biopsies every year. I'd rather have accurate surveillance. So what accurate surveillance would mean is I know what's in the patient's prostate. I know that that patient only has Gleason 6 with a very high degree of certainty. I don't need to do repeat biopsies. I can, in fact, say, come back in 5 years and we'll check your PSA. You don't need another biopsy. If we believe the grade progression risk is only 1 to 2%, in 5 years it's only 5%, we probably can just check the PSA. We don't need to do another biopsy. Here's the other issue with MRI, and this is fairly well known now, and that is you can't rely on the MRI to accurately describe the boundaries of the cancer as represented on the whole mount prostatectomy specimen. So there's the whole mount on the left, there's the MRI on the right. The red is the lesion from the whole mount, the green is the lesion identified by MRI, and the median difference between the boundaries was 1.3 centimeters, but you can see it's all over the place. In some cases it's close, in some cases it's far away. So if you're using MRI to target a lesion for focal therapy, you really don't know how large to make the ablation area or zone, and that's why people talk about, well, maybe we should do a hemiablation, but that's not really focal therapy. It's like saying, going back to the breast model, let me take off half the breast, because I'm not sure really what the size of the lesion is. Of course, we don't have that problem because imaging is much better with breast cancer because you're not finding a lesion without the imaging. Okay, so the other thing is, let's talk about using MRI for surveillance. This is again from UCLA, and the patients had a biopsy, they had an MRI, they came back and had the work repeated, and they found 30% at 1 year had clinically significant disease, even though they were put on surveillance with MRI and biopsy. And of course, that 30% is the same number we're seeing all the time, that both the biopsy and the MRI at the outset missed about 30% of the men who had clinically significant cancers. These are not new cancers that are arising. These are cancers that are growing over time, and then they're becoming easier or to target by either MRI or systematic biopsies. Okay, this is a paper that was recently published by Lepore's group at NYU, and Peter knows, probably Laurie knows too, Samir Taneja is the urologist who's done all the MRI work at NYU. He's got a brilliant mind like Peter Pinto in figuring out who has cancer, who doesn't have cancer. They even have a 7 Tesla unit at NYU to look at the prostate. So they did a study. They decided they would use the MRI information to plan out a focal therapy on patients. They weren't doing the focal therapy. They took the patients to the OR and did radical prostatectomies, and they found that 49% of the lesions in this small group of patients, there were 59 patients, had clinically significant grade 4 cancer outside of the planned focal therapy field. So this just substantiates the information I showed you before, that the MRIs, even in their really expert hands, are not finding all the lesions to make focal therapy a safe approach using MRI as the methodology for lesion or patient selection. So let's talk about mapping biopsies. This is what a transperineal biopsy looks like. The urologist is going through a brachytherapy grid, and he's looking at an ultrasound screen, and you can see he sees the needle on the lower screen, and he's taking a sagittal image biopsy there. So why is it only done 5% of the time? Why isn't it done 95% of the time? It's so wonderful. And there are so many limitations on what we're doing today because of needles we have. Just take a small piece of tissue. They don't span the length of the prostate. They deflect, so they don't go straight. So it's very hard to represent that needle if you have any software. There's really no good software that provides real-time tracking, representation, and recall. We have great brachytherapy software. I mean, that's just fabulous. If you're doing a seed implant today and you're not using the computer imaging software, you're in the dark ages. That's treatment. We don't have that for biopsy. We have systems for transrectal biopsy. We do have the MIM system for transperineal MRI-guided biopsies, but they're still very limited and they're cumbersome to use. And the systems we have to manage the tissue have not changed in 100 years. Basically, we're just taking a piece of tissue and dropping it in formalin and sending it to the lab and asking the pathologist to give us meaningful information. So if you want to have a mechanism that solves all the problems, that gets back to the point, find the high-grade lesion when it's small, interrogate the prostate and know there's nothing else there besides Gleason 6, you can't have one thing. You have to have many things in a system that will allow you to get to that answer. So let's talk about software. So this was an article written by Kepner and Kepner in 2010. It was published. And what they hypothesized is if you drill holes in the prostate, and those biopsy sites are parallel, you could calculate out, based on the diameter of the needle you used and the spacing between the biopsy sites, the unknown zone represented by that sphere there. So in other words, if you use a 15-gauge needle and your needles are spaced at 5 millimeters using a brachytherapy grid, for example, so you're ideally spacing these biopsy sites, and you could take one biopsy from apex to base, the zone of uncertainty, which you're not biopsying between parallel needles, is 3.5 millimeters, simple math. So if you take 3.5 millimeters and you apply the volume of a prolate ellipsoid, so that's the diameter times 3 divided by 2, the volume would be 0.02 cubic centimeters you would miss. Very small. And that math is easy to apply. So if you said, no, I'm not going to take biopsies every 5 millimeters, it's too much work, even though your needle goes all the way through the prostate as one core. I want to take biopsies at 1 centimeter. So let's take biopsies at 1 centimeter. Biopsies at 5 millimeters, taking one biopsy from base to apex, equals about 1 biopsy per cc. So you'd be doing, average prostate size is 36, you'd be doing 36 biopsies on that patient. But let's say I don't want to do that many biopsies. I only want to do 18. So now I'm taking a biopsy every centimeter. What's the math? So the math would be 10 millimeters between the needles. The needle has a diameter of 1.5 millimeters, so that's 8.5 millimeters. That's the unknown zone. 8.5 millimeters times 3 divided by 2 is 0.3. So I can find a tumor now that's 0.3 cubic centimeters, which is just about the zone I want to be in if it's a Gleason 8, because Gleason 8s start getting bad once they get above 0.2 cubic centimeters. So you could put this in the control of the urologist, for example, who's doing the biopsies, because you can select what you want to do. You're not limited to anything rigid. You can even say, all right, I'm going to do the MRI and use the MRI as the target. So I'm not ruling out the MRI. I can biopsy the target, but then I can take another, let's say, 12 to 14 systematic biopsies, but I'm taking it with this methodology because I know along with the target and the other biopsies I've taken, I'm only going to have the potential to miss, if I'm doing it at 1 centimeter, a lesion that's larger than 0.3 cubic centimeters. So that's the theory. So this is the first software that we built. I built with Dr. Craig Baer, sitting back there, working. I retired from clinical practice in 2012 and moved to Colorado, and Dr. Baer's software firm is in Colorado Springs, so I bought all the equipment and I just drove back and forth from Vail, and we worked on this for 2 years to develop this. And this is the first version, showing the yellow dots are the 5 millimeter biopsy cores, and you get a dialog box that tells you the location and how long the length of that core needs to be to go from base to apex. We tried that out for a year clinically, tag along in Dr. Crawford's practice to see how it worked, and we were very happy. Keep in mind that this was built by a urologist, so I needed, knowing the anxieties and the stress that we had to go through in training people on the computer doing brachytherapy, we had to make this very easy for physicians to use, and we had to make it low cost. So we accomplished both of those, I hope. So now there's Dr. Skouteris in Greece using the beta version. So you can see the image below is just the sagittal of the prostate with the needle going in right here. And here is the representation showing the virtual needle. This looks like the MRI type software, nothing so fancy about it. But there are some very large differences, one of them which is that the needle will go from the base to the prostate, so you actually get the notch representation of the notch here spans the entire length of the gland. And then, just like brachytherapy, you can move the virtual needle so it overlaps the actual needle in the prostate. So similar to brachytherapy, the representation is what you're actually doing. Okay, the biopsy devices then needed to be changed too. So here's the first problem we had to slide. This is our representation. You see the straight needle here, and then you see the needle taking the biopsies going zoop. And so we all know deflection is an issue. It's really a big issue too for MRI. I've seen several presentations where they showed anterior lesions and they were trying to biopsy them, and they actually showed the video. You saw the region of interest up here anteriorly, and the video showed the needle going in, and it's getting towards the lesion, and it just curved off because the lesion was stiffer than the actual cancer. So we had to solve this problem of deflection, and we looked at lots of different types of needles. We took the standard barred needle, which is a lancet tip. We made a lancet tip needle also, and then the cannula, we tried different points on the cannula, which cuts the tissue in different angles. And then we also tried, instead of a lancet tip needle, which is like the tip of a needle you use to draw blood, we made trocar tips needles. So they look like a spear, basically, a 4-point spear. And we found that though this needle here had the least deflection, it was basically almost 1/10 the deflection in terms of degrees, the mean difference in the testing between the barred needle and this. So this is a needle we ended up with because it had the least deflection of any of the needles we tested. And here's how you test it. We built a hydrogel, and we made the density of the hydrogel similar to prostate gland density, and we fired the needle through the hydrogel, and you can see here the idealized straight, and there's the deflection, and here you see the idealized straight, and there's very little deflection on the testing. So it took a couple years to figure all these points out, and it wasn't just a matter of the tip of the needle. It was a matter of the tip of the needle, the way the point on the cutting portion of the cannula was ground, and the angle of the grind. Because if you can imagine, the needle shoots out first, so that's got the notch in it. So that's got to shoot straight. It's not going to go like this. And then as the cannula comes over the notch and it starts to cut the tissue, if it's not cutting the tissue cleanly, it starts to push the needle down. So then there's deflection caused by the initial needle going out, and there's deflection caused by the cannula coming over the notch. So by working out those geometries and forces, we were able to get to a needle that has virtually no deflection when you fire it. What about core length? There's a study that showed that when you take a biopsy, now keep in mind the average core length for a 20 millimeter standard biopsy true cut needle today is 60%. It's 12 millimeters. You get an average of 60%. So there have been a number of studies in the literature that showed when you compared what you got with a standard needle, the patients who had more length to their cores, there was a greater diagnosis of prostate cancer. So core length matters. So we had to figure out now, how are we going to get core length? Because again, when the cannula comes over the notch, it pushes the tissue towards the far end of the notch, and so you don't end up with a full core, and the core often gets fragmented as the cannula starts to drag the tissue over that flat area. So we hypothesized if we built these ridges into the bottom of the notch, that as the cannula starts to push the tissue, the notches are going to hold the tissue in place, and then you're going to get a full core. So that's how we decided to build that. And we tested that in porcine kidneys. We published this last year in Urology, and you typically get 90 to 95% of the length you want because the cores are doing a great job of holding it in place. So this is what the device looks like, and it's, again, build it so it's similar to what urologists are familiar with. So it's just you cock it once or twice with a lever. There's a insertion tool with a needle. It looks exactly the same as you would be using the current needles and guns out there that are reusable. So we made it all very similar. So this is probably the most important part of the whole exercise. If you got a specimen that was 5 centimeters long, so you're taking a biopsy, 1 core base to apex, what are you going to do with that 5 centimeter piece of tissue? If you put that in a vial and send it to pathology, it's going to be in a bunch of pieces. There's no way the pathologist is going to tell you where the cancer is on that core, because you need that information if you're planning to do focal therapy. And the tissue processing cassettes are 3 centimeters long, so it's not going to fit in it anyway. So we had to figure out how to solve that problem. So this is what we do now. We just pick up the tissue with the needle, we drop it in one of these vials, and we keep our fingers crossed that it's not going to get mixed up. And you also have to realize there's a 3% mishandling and labeling error associated with prostate cancer. We've all seen patients who had a diagnosis of prostate cancer, and we've taken out the prostate, and there's no cancer in it. Can you imagine taking 30 biopsies in the OR? And you know how we work. You can do this mapping biopsy you can do in 30 minutes with the right tools. And you're giving specimens to the nurse, and you're shouting out where they came from. And halfway before she's done, she's wrote down the wrong number. So if you told her from the grid that's coming from A 3.25, and she writes down B point something or other, and then you got your report back, and you got 30 biopsies, and there's a Gleason 7 at this one point that's showing up on your report, but that's not where you took it from, that's going to give you the wrong area to do your focal therapy. So specimen provenance is extremely important, as well as specimen integrity in this situation. So this is the device we developed. This was hard work. So there's the longer needle, and this is a cadaveric specimen. And this 6 centimeter specimen coming out on the specimen collection device, we call it the integrated pathology system. It's going to have a UPC code and a number. So UPC code identifies the patient. The number identifies the site it came from, 1, 2, 3, 4, 5, so it's easy. The specimen is placed on the Velcro-like strip, which is tacky, so it holds the tissue from the needle when you roll the needle across it. And then it has a strip you remove that's got adhesive, and you fold it over, and now the specimen is sealed in this Velcro polyester fiber device. It's translucent, so when it gets to pathology, it's numbered 1, 2, 3, 4, 5, because the first thing the pathologist will do is record its size, so the pathologist no longer needs to measure it, because the measurements are already there. It goes into formaldehyde. It is processed in that device. It gets cut in half, put in the tissue processing cassette, and never removed from the device, and goes through all the steps of tissue processing, paraffin embedding, sectioning on the microtome, and staining without ever having to be touched. Because the technologist doesn't need to touch the specimen does not get disturbed. You eliminate biohazard risks to the technician because he or she is not touching it, and you preserve the integrity, and you also actually eliminate 25% of the handling steps in the pathology lab. So one of the criticisms of doing so many biopsies is that the pathologists are not getting paid for the time it takes to process. By getting rid of the handling of the specimen and eliminating 25% of the steps, you actually save a considerable amount of time in making the cost efficiency of managing more specimens more effective. So that was required to solve the last part of the problem was tissue management. So in conclusion, a 3-dimensional transperineal approach utilizing software, a newly designed needle and gun and pathology carrier system has the capability of detecting lesions smaller than 0.1 cubic centimeters. Can this platform serve as a virtual prostatectomy? So that's going to be the step. Once we get this out, it has to be tested. So the testing will be done as identify patients for active surveillance. So they've got 1 or 2 cores, Gleason 6, PSA less than 10, T1C prostate cancer. They need to have a confirmatory biopsy. So we're going to take these patients and subject them to this technology. 1/3 of them are going to have surgical disease because that's what the data shows. They're upgraded to Gleason grade 4. I think we're going to identify the bulk of those patients. They're going to go and have a prostatectomy. The prostatectomy specimens, as Dr. Lucia showed you, will be hole-mounted and digitized. The 3D biopsy file will allow you to have the same digitized result. Those two will be slapped together by a co-registration, and then we'll be able to see whether indeed the technology here identifies virtually all the lesions. And if it does, and I think it does, and it will also identify the size of the lesions. Now, as I said yesterday, The technique is going to be dependent on the urologist. The nice thing about this platform is you're going to be able to move those virtual needles over the actual needle you put in the prostate. So if anybody's done brachytherapy and you stick the needle through the grid and you say it's got to end up here, it's never going to, not never, but usually it's going to be 1 or 2 millimeters away. So you already got some discordance between what you want and what the result is. But you'll move the virtual needle so it overlies that point. And if the next needle is 6 millimeters away and not 5 millimeters away, you'll have that representation. So at the end of the case, you have a documentation, just like you have with brachytherapy and you know where the seeds are, you're going to have documentation of what you did in that case. When you get the pathology back, let's say there are 2 lesions with Gleason 7, different parts of the prostate. The distance between your positive needle and your next needle over to the right, left, below, or to the other side are the zones of unknown. So all the needles around your one lesion are negative. The uncertainty is going to be between the positive needle and the next negative needle. So you can now virtually have a zone of theoretical ablation that goes out to the next negative needle. So if you're 5 millimeters apart, then that zone is 3.5 millimeters. If you're 8 millimeters apart, then that zone is 6.5 millimeters. Remember, the width is 1.5 millimeters. So you'll know with a high degree of certainty, I believe, that if you ablate that area with the surrounding needles being negative, the length you know, because you have the whole length in your specimen, that you'll have 100% theory, reliability that you will ablate all the cancer in that zone, regardless of what energy you choose. That's a whole nother issue. So in looking at the prostatectomy specimens, correlating them back to the mapping specimen, we'll be able to model all that out and know whether or not that actually addresses that problem. How big of a zone do you need to ablate? So now I'm getting away from what John said the other day, well, we'll just do half the load because we have so much uncertainty. If we have a lot more certainty, then maybe then we can actually do true targeted focal ablation. My other concern, and I'm just going to finish up now, is we talk about hemiablation, or we talk about hockey stick ablation, and we say, well, we're leaving a quarter of the prostate or whatever. I don't know what that's going to be like in 15 years. And we're going to talk about the long-term brachytherapy data on Sunday. When I reported our 10-year brachytherapy data at quality of life, it looked pretty good. Now I'm reporting 15-year data. It doesn't look nearly as good. So if I'm having a 58-year-old man and I'm doing targeted focal therapy, I got to have a little more assurance that 15 years later, when he's 73, he's still functioning very well. But if I'm doing a hemiablation or 3/4 ablation, I'm not so sure that's going to be true. So what we know today in the short term, just like with Dr. Klotz's active surveillance patients, in 10 years, the first few years, 10 years even, after patients who had Gleason 3+4, they look pretty good. But now we've got 15-year data. We're thinking maybe that wasn't the right choice for active surveillance in those men. And I fear that's going to be true with targeted focal therapy. First of all, I don't think focal therapy should be done today because I don't think we're there with lesion identification, but I think we can get there. So we need to demonstrate proof of concept. These are still theoretical. Nothing is available for clinical use. We will get there, and I am very excited that this is going to be, I hope, a great addition to our armamentarium, including MRI, and how we figure out who to surveil, who to treat, and how to treat them. Thank you very much.